Thank you, everybody. So, I'll be speaking on updates in the management of febrile neutropenia. Since a lot of paramedics are in the audience, I would like to highlight first febrile neutropenia is a medical emergency, just like a heart attack and a stroke. So, we should counsel our patients before starting treatment itself, and our paramedical staff can help us in the same. So, starting with the definition of febrile neutropenia, a single oral temperature of more than 101 degree Fahrenheit or an oral temperature of 100.4 degree Fahrenheit sustained for an hour or that occurs twice within 24 hours period, and neutropenia of NC count less than 500 or NC less than 1000, but that is tending to decline in less than 500 in next 48 hours. So the frequency of infectious agents in our patients, bacteria is identified as 70 to 90% cause, while fungus in 5 to 20% cases. So in patients where there is low incidence of febrile neutropenia, bacteremia can be identified in up to 10% of the patients, while it is unknown cause in up to 70% of the patients. However, in case of high incidence, the bacteremia is the identified cause in about 35% patients with unknown origin or unknown cause in up to 50% cases. Microbiology, gram-positive organisms include Coagulase negative Staph aureus, Staph aureus viridans. In gram-negative, E. coli, Klebsiella, Pseudomonas. Yeast includes Candida aspergillus, and rarely in cases of virus includes HSV, CMV, and influenza virus. So these are all the data from the West. Do we have our own data? Yes, we have our own data also. This is a recent publication in the Indian Journal of Critical Care Medicine in 2019 January. This included the various data which has been yet published from our own country. This includes two large publications. One is of 484 isolates. The chief author was Kumar Prabhas sir, in which we found that the Pseudomonas was 30% of the all isolates. And another publication by Manju Sanger ma'am, which included 739 isolates. The E. coli was 20% and Pseudomonas was again near about 19%. So in a patient with febrile neutropenia, suspected febrile neutropenia, the initial investigations include, as per the standard, the history and physical examination, laboratory assessments, and imaging. So history and physical examination includes the chemotherapy regimen given, when was the last dose given, if the patient is having any vascular access device, if the patient was on any prophylactic antibiotic, has the steroids been used, if the patient has any allergy, apart from the routine concurrent comorbidities and surgical procedures. Also, we should concentrate on the site-specific history. That includes the history for mucositis, infections, recent cough, GI disturbances, and all. So, CBC with differential counts, renal function test, electrolytes, liver function test, and urine analysis in a suitable patient. So, coming to the microbiological evaluation, here we have our own guidelines in which we have the clear recommendations that at least two set of blood cultures should be collected, with a set collected simultaneously from the peripheral site and one from the central line. If the lumen catheter is a multi-lumen catheter, one set per lumen should be collected. If the patient does not have any central catheter, two blood culture sets from separate venipunctures should be sent. And it is important to know that each ml of the blood increase the yield of blood cultures in adult by approximately 3%. And collection of two blood culture sets provide 80 to 90% yield of bloodstream infections in critically ill patients. And one set includes, what is one set of culture? One set includes both aerobic and anaerobic culture bottle, and blood culture volume should be at least 10 ml per bottle. This 10 ml per bottle is for an adult. If if there is a patient of weight less than 25 kg, it is approximately 70 ml per kg is the blood volume, and we ask our sisters to collect about 1% per unit blood volume. So, for example, if there is a 10 kg child, approximately blood volume will be 700 ml. So, we'll ask sisters to collect 7 ml for culture. Urine culture to be collected if patient is symptomatic, patient is on urinary catheter, or if there is a abnormal urinalysis. Site-specific cultures will be required. In case of diarrhea, also we'll do C. diff assay. We have our own enzyme immunoassay kits, which includes the DH, toxin A, and toxin B testing. Other than that, sputum cultures as per the requirements. And since we are using a lot of central venous catheters in the form of PICC, the swab or biopsy of any skin lesions, and viral cultures if symptomatic for the same. So initial therapy depends on a lot of things, and we need to individualize the treatment and take into account various assessments previously done as discussed, the patient assessment, site of infection, how is the organ function of the patient, if there is any allergy, previous history of antibiotic use, potential organisms suspected, local susceptibility as per the hospital data, broad spectrum requirement, and anti-subdermal requirement. So, Om sir has already highlighted the use of MSCC score. It is a prospectively validated tool to rapidly assess risk before assess to neutrophil count. And score more than 20 are at low risk of complications. So this score includes burden of illness, presence of hypotension, COPD, patient is of solid malignancy or hemat malignancy, and patient outpatient representation or needed inpatient admission, and if the age is less than 60 years. This age less than 60 years does not include patients with less than 18 years of age, because in the study which was using this for validation, less than 18 years patients were not included in this study. So this last point is not valid for patients of less than 18 years. So there's also a Talcott's rules which divides the patient to group 1 to group 4. Group 1 is for inpatient at the time of fever onset. Group 2, patients with acute morbidity requiring hospitalization. Group 3, outpatients without comorbidity but with uncontrolled cancers. And group 4, outpatients with cancer controlled and without comorbidity. And these are considered low risk. So there has been an ESCO update in 2018 May, in which a new tool has been added to the previous tools. It is called Clinical Index of Stable Febrile Neutropenia, CISNEG. This is for more than 18 years patients with FN who appear to be clinically stable after chemotherapy for treatment of solid tumors. So this is applicable for more than 18s and only for solid tumors. This includes ECOG performance status of 2 or more, COPD, cardiovascular disease, mucositis of more than grade 2, monocyte count less than 200, and stress-induced hyperglycemia. Please mind that here there is monocyte count. And as per the scoring, 0 patients are given to low risk, intermediate, and high risk, and the score is 0, 1 to 2, 3 or more is high risk. And risk of complications increases from 1 to 6% and jumps from 6 to 36%. So even the low risk, the patients who appear to be low risk, if on scoring are coming to be 3 or more, they are at very high risk of complication and need inpatient admission. Low risk patients, that as previously discussed, the patients who don't appear to have any focus on infection, no systemic symptoms other than fever, if the patient's organ functions are normal, there's no CVID, patients counts appear to be recovering, that is monocytes counts is high but neutrophil counts are only low, and patient is reliable for follow-up, then we can consider vigilant observation and ask the patient to return to clinic if any cultures come to be positive, or if there is persistence of fever or reappearance of fever after 3 to 5 days, and if patient is unable to tolerate oral regimens. The usual regimen prescribed is ciprofloxacin plus amoxiclav. However, we can also use cefuroxime. For high-risk patients, we advise IV antibiotics and, if possible, admission. And beta-lactam antibiotics plus aminoglycosides is the standard regimen. So there's data to suggest that if we start antibiotics at the first appearance of fever, then mortality is reduced from 50% to 25%. That means if we give first dose of antibiotic before the results are available, it definitely reduces the mortality. And it is the standard recommendation that we should give first dose of antibiotic within 1 hour of presentation. FN in high-risk patients, as per the ITSA guidelines, should be started on an anti-pseudomonal penicillin. Our own data is in agreement with this, as up to 30% patients had isolates of pseudomonas in the cultures. Or the other option is to use a single-agent carbapenem or use of a fourth-generation cephalosporin. Also, aminoglycosides should be added if there is severe sepsis or septic shock, high incidence or suspicion of Pseudomonas aeruginosa, or if there is pneumonia. Glycopeptides like vancomycin or teicoplanin should be added if there is patient is in shock, if there is catheter-related infection is suspected, or there is suspicion of gram-positive infection, skin or soft tissue infection, and pneumonia. Here I would like to add, in addition to these guidelines, that in most of our patients, we are using both combination of beta-lactam inhibitors along with aminoglycosides, because our patients are exposed to higher risk of infection in view of the poor hygiene and less chances to present to us if there are complications. Vancomycin is, as discussed, not routinely used, but is added in specific situations as just highlighted. And there are specifically two approaches for empiric therapy of febrile neutropenia. It includes escalation or de-escalation approaches. And coming to antifungals, Om sir has already included antifungals in the treatment, so I would not discuss it. ITSA guidelines recommend to add antifungal if febrile for more than 3 days and patient still remains neutropenic. Especially in conditions where patients have mucositis with diarrhea, duration of neutropenia suspected is more than 10 days. In such cases, we need to add antifungals. And our recommendation is to continue antifungals till neutropenia is resolved or for at least 14 days if the fungal infection is demonstrated, or to stop if there is no fungal infection demonstration. Indian antimicrobial prescription guidelines suggest to use caspofungin as the first antifungal. Anidulafungin and micafungin are used if their contraindications to is caspofungin. Voriconazole is the first line for aspergillosis. In patients with renal dysfunction, caspofungin can be given instead of IV voriconazole, and liposomal amphotericin B is the standard drug of choice for suspected mucormycosis. So assessment of response is the standard as per the clinical CBC, renal functions, and the clinical symptoms. Duration for skin soft tissue 7 to 14 days. For sinusitis, it extends up to 21 days. Also for bacterial pneumonia, it extends up to 21 days. Thank you.